Over 40% of American adults now meet the clinical criteria for obesity. Demand for bariatric care has never been higher, but inside the clinic, that demand is piling up on the desks of your support staff. That demographic reality translates into more than 250,000 bariatric procedures performed in the U.S. every single year. But there is a frustrating paradox here. A growing patient waitlist should lead to increased revenue. Instead, it creates a crushing administrative volume that stresses your team and delays patient care. Running a bariatric practice today involves managing one of the most administratively complex workflows in all of outpatient medicine. Bariatric surgery is a documentation-heavy process. Every case requires extensive preoperative preparation and meticulous record-keeping before a surgeon ever picks up a scalpel. This chart maps out the typical bariatric prior authorization loop. Each payer sets its own rules. One carrier might require 6 months of medically supervised weight loss, while another demands a documented 2-year BMI history alongside psychological evaluations and specific letters of medical necessity. In this system, perfection is the baseline. Missing a single progress note or incorrectly formatting a psychological evaluation triggers an automatic denial. Because of these rigid, shifting criteria, nearly 25% of bariatric patients are denied coverage up to 3 times before getting eventual approval, trapping revenue in an appeal cycle. For a medium-volume program performing 300 surgeries a year, reducing pre-authorization denials from 28% down to 10% recovers more than $500,000 in delayed or lost revenue. Prior authorization acts as the primary bottleneck, directly limiting practice growth and revenue realization. And the people tasked with managing this bottleneck are leaving. Medical group data shows the turnover rate for support staff has hit 40%. When a trained specialty coordinator leaves, they take months of highly specific institutional knowledge about payer rules with them. This waterfall chart breaks down the true cost of an in-house hire. When you combine the base salary of a local administrative worker with benefits, payroll taxes, office overhead, and the constant cost of recruiting and training replacements, the loaded annual cost reaches $60,800. Practices are paying premium, compounding wages to maintain an unstable system that risks documentation errors every time a new employee sits at the desk. The traditional approach is to pile bariatric authorizations onto general front desk staff. But managing complex multi-payer criteria is difficult to sustain alongside routine patient intake and scheduling. This quadrant chart plots staffing approaches. On the top left, generalist staff require high effort but yield low revenue impact due to inevitable errors. Industry best practice sits on the bottom right, creating standardized pre-authorization bundles and payer-specific matrices. To reach that high revenue impact, you need a dedicated coordinator whose sole focus is navigating the intricate, constantly changing rules of Aetna, Blue Cross, and other major carriers. Relying on a generalist to manage specialized, high-stakes medical authorizations is a structural error in your workflow, not a personnel problem. This is why a growing number of bariatric programs are moving away from local hiring in favor of dedicated virtual medical assistants, or VMAs, through Staffingly. Each client receives a dedicated specialist who manages the complete administrative workflow, handling insurance verification, prior authorization submissions, appeal support, and compliance tracking. Your Staffingly VMA connects securely and directly into your practice's existing electronic health record system. They learn your specific workflows, your payer mix, and your patient population. Every engagement comes with a structured management layer, including a team leader for daily supervision, a process manager for quality control, and weekly performance dashboards to track turnaround times and accuracy. You are replacing the volatility of a single local employee with a managed, scalable infrastructure that stays in place even when individual personnel change. Staff typically spend about 13 hours a week on prior authorizations. Human fatigue naturally leads to documentation errors, which lead to 2 to 4 week delays. This diagram shows how Staffingly layers AI over their human team to catch incomplete data and unusual payer rules before anything gets submitted. As tasks arrive, auto-categorization technology triages them based on urgency and the specific actions required. Simultaneously, machine learning algorithms continuously scan the queue, flagging unusual edge cases or missing records and routing them to a supervisor for review before a carrier can issue a denial. Layering AI quality controls on top of a dedicated, trained human team transforms the prior authorization process into a predictable, trackable workflow. This comparison matrix lays out the core business decision. The traditional in-house hire carries a true loaded cost of nearly $61,000. A dedicated Staffingly VMA costs $21,600. That's a 64% reduction, saving $39,200 annually. The financial math heavily penalizes practices that continue to rely on local hiring for standardized administrative tasks. While transitioning systems often feels like a source of operational friction, this onboarding is built for speed. The process starts with a discovery session on day 1. Most practices go live within 48 to 72 hours and reach full operational capacity in just 14 days. You can validate this 99% accuracy model through a 2-week risk-free pilot with no long-term contracts. You can continue to manage surgical backlogs and the constant headache of retraining staff, or you can implement the scalable infrastructure ready to capture rising patient demand. Ultimately, the smartest way to grow your surgical volume is to completely disconnect it from the growth of your overhead.